Imagine being asked to build an entirely new, fully functional room onto a house. But there is a massive catch.
Right, a pretty huge one.
Yeah, you are legally banned from going to the hardware store for extra lumber or drywall. You are, strictly restricted to using only the building materials that already exist right there in the living room.
So you have to tear down the walls, pull up the floorboards, and somehow reshape those exact same materials into a completely different architectural structure.
Exactly. It's wild. And today we are taking you into a surgical landscape that does exactly this to the human body. We're diving into the incredibly complex world of reconstructive genital surgeries, specifically vaginoplasty and gender-affirming lower surgery.
It really is fascinating. You're asking a living organism to adapt to an entirely new structural reality, but you're using only the tissue it already has. It's the absolute definition of a biological frontier.
Welcome to today's deep dive. We are taking you through a massive stack of medical literature, clinical guidelines, and some really wild surgical case studies.
Yeah, there's a lot of ground to cover.
There really is. But our mission today isn't just to talk about the surgical procedure itself. The real mystery we are unpacking for you is what happens after. Like, how does the human body react to being radically rearranged?
Which is usually by fighting back.
Right. And most importantly, and this is kind of the core focus for our deep dive today, when the body's natural healing process stubbornly creates complications, things like asymmetrical healing, wound separation, or severe scar tissue, can it actually be corrected?
The human body is just a fiercely stubborn organism. It prioritizes survival over aesthetics, like every single time.
Yeah.
It will fight back and attempt to heal in ways that might completely oppose the structural blueprint the surgeon was trying to achieve in the first place.
So to understand how those complications happen and how they get corrected, we really have to look at that initial blueprint. The sources detail the biological mechanics of what is widely considered the gold standard for this type of surgery, which is the penile inversion vaginoplasty. And going back to our architectural analogy, the primary rule is repurposing existing anatomy, right?
Exactly. Surgeons are essentially performing this massive tissue transposition. The penile skin is inverted to line the newly created vaginal canal,
Okay.
and then the scrotal skin is meticulously preserved and reshaped to form the labia majoriso, the outer lips.
Right, the outer structure.
Yes. And the glans, which is the highly sensitive head of the penis, is separated from its surrounding erectile tissue. But, and this is crucial, it's kept attached to its primary nerve bundles.
So it keeps the sensation.
Exactly. It gets repurposed to create a fully sensate clitoris.
One of the most fascinating details I found in the clinical notes, though, is what they deliberately choose not to move. They actually leave the prostate right where it is.
Yeah, because removing the prostate involves dissecting a really dense, highly complex web of urinary structures and autonomic nerves.
Which sounds incredibly risky.
It is. Disrupting that network drastically increases the risk of lifelong complications, particularly severe urinary incontinence.
Yeah.
But beyond just avoiding damage, leaving the prostate in place serves a vital functional purpose.
Right. It acts as the anatomical equivalent to the G-spot.
Exactly. Because it sits right against the anterior wall of the newly created vaginal canal, it maintains a highly accessible erogenous zone, just, utilizing the body's existing neuroanatomy.
So we have this incredible feat of structural engineering happening, but because you are doing all of this major moving, reshaping, and suturing in a single operation, what the literature calls a one-stage surgery, you run headfirst into a brutal biological limitation.
Yeah, the building materials are pushed to their absolute breaking point.
Right. The wall you hit is blood supply.
Tissue can only survive if it is continuously fed by a robust vascular network. When a surgeon takes scrotal skin, penile skin, and the glans and, stretches them, rotates them, and pulls them into completely novel positions.
Stretching the vessels.
Exactly. They're placing immense mechanical tension on the blood vessels that feed those tissues. Think of a blood vessel like a garden hose.
Okay.
If you pull a garden hose too tight, it stretches, it narrows, and eventually it just cuts off the flow of water entirely.
So if you stretch the tissue too far, trying to make it look cosmetically perfect on the operating table, you cut off the oxygen.
And the tissue will literally die. It undergoes necrosis. The inherent limitation of a one-stage vaginoplasty is that the surgeon is entirely at the mercy of that existing blood supply.
They can only go so far.
Right. They can only manipulate the tissue as far as those stretched blood vessels will safely allow.
Which brings us directly to the core focus of today's deep dive. Because the surgeon is fundamentally restricted by blood supply, The body heals based on sheer survival, not symmetry.
Aesthetics take a backseat.
Totally. The sources explicitly note that after a one-stage procedure, it is incredibly common for the body to settle in ways that are uneven or asymmetrical. The labia majora might end up spaced far too wide.
Or there might be minimal clitoral hooding.
Right, or the labia minora just isn't sufficiently defined. Sometimes patients even experience skin webbing across the anatomy.
And for a patient waking up from a major life-altering surgery and eventually observing these physical asymmetries, it can trigger immense psychological distress.
Oh, absolutely.
The expectation is often a perfectly centered textbook result, but the biological reality of the tissue simply doesn't allow for that in the first stage.
Wait, let me push back on this a little bit. If the medical community knows that blood supply limits mean the tissue is inevitably going to settle unevenly, why do a one-stage surgery at all? Like, why not just plan a two-stage procedure from day one instead of letting a patient wake up to a highly distressing asymmetrical result?
That's a great question. The calculus there really comes down to surgical trauma versus aesthetic convenience, subjecting a patient to two major pelvic surgeries back to back.
Oh, because of the anesthesia and everything.
Exactly. With all the associated risks of general anesthesia, deep tissue infection, deep vein thrombosis, and just systemic shock, it's incredibly dangerous. The safest approach is to do the heavy lifting in one stage, secure the structural integrity, and most importantly, let the body establish a brand new, robust vascular network in that area.
So it's not a botched surgery when things heal asymmetrically. It's a calculated, necessary biological compromise.
It is entirely necessary. The initial surgery is exclusively about getting the tissue to survive its new placement. Once 3 to 6 months have passed, the surgical environment completely changes.
Because it's healed.
Right. The body has laid down new blood vessels, the tissue is healthy, heavily vascularized, and structurally settled.
So the architectural foundation is finally solid, which means you can safely go back in and do the cosmetic finishing work to correct the asymmetry.
This is exactly why secondary operations, often called revision surgeries or a secondary labiaplasty, are incredibly common and, more importantly, they're highly effective.
Because you aren't fighting the blood supply anymore.
Exactly. Because the surgeon is no longer fighting the body's emergency survival mode, they can safely make incisions to release webbing, bring the labia closer to the midline, or properly define the clitoral hood. They can finally prioritize aesthetics and functional symmetry without the terrifying risk of the tissue dying from oxygen starvation.
That makes so much sense. And that stabilization of the tissue also dictates how the surface skin behaves, particularly when it comes to scarring, right? We are talking about serious incisions across highly mobile areas of the body. How do surgeons manage the external scars once that initial reconstruction starts to tighten up?
Well, scars are basically the body's biological superglue. It's a rapid, chaotic production of collagen fibers trying to bridge an open gap as fast as possible.
Right.
But unlike normal skin, which has an organized basket weave structure that allows it to stretch and move, scar tissue is laid down in dense, parallel lines. It is rigid. And in gender-affirming surgeries, managing that rigid tissue is a massive part of the recovery process.
The sources outline some brilliant techniques for managing this rigidity. The one that really stood out to me is called a Z-plasty.
Oh, Z-plasty is a masterful reconstructive technique. It's used to correct scars that are pulling the skin too tight and restricting normal movement. Imagine a straight scar acting like a very tight guitar string pulling across the skin.
Okay, I can picture that.
A surgeon will cut two small triangular flaps of healthy skin on either side of that scar, essentially forming a Z shape.
Then they literally transpose or swap the positions of those two triangles. But how does just weaving the skin into a new pattern fix the tightness?
By swapping those triangles, you are effectively breaking that straight guitar string into a zigzag.
Yeah.
You actually lengthen the scar itself, which instantly gives the surrounding skin slack.
Oh, wow.
And more importantly, it allows the surgeon to physically rotate the direction of the scar so that it hides within the natural folds and tension lines of the body. It is entirely tissue-sparing. You aren't removing a single millimeter of skin. You are simply redirecting the mechanical tension.
Mechanical tension really seems to be the invisible enemy here. To give you some context on how powerful that tension is, the sources look at other lower surgeries, like abdominal phalloplasties for transmasculine individuals.
Right, those are intense.
Yeah, in some of these procedures, patients can be left with a painful 6-inch transverse scar straight across the abdomen. That kind of rigid collagen line fundamentally alters the entire landscape of the abdominal tissue, which makes any future corrective procedures infinitely harder to perform.
Because the skin is constantly being pulled by the muscles underneath. And even in surgeries with smaller, more localized incisions, like a vaginoplasty, the simple acts of sitting, standing, and walking create massive mechanical tension.
Everyday movement.
Exactly. And that constant pulling leads to another highly common complication, which is dehiscence.
Dehiscence, which is the medical term for wound separation, like the tissue literally pulls apart at the suture lines.
It occurs most frequently right at the entrance of the vaginal canal or along the perineum, simply because those areas bear the brunt of the body's mechanical load. The sutures hold, but the fragile, healing skin around them just gives way.
The clinical guidance for patients experiencing this is fascinating and honestly surprisingly low-tech. Patients will often notice this wound separation and then they see this thick, yellowish discharge coating the area.
Which is terrifying for them.
Right. The immediate thought is that it's a massive, localized infection, but the clinical notes explicitly point out that this yellow substance is usually just fibrin.
Fibrin is a key protein involved in blood clotting. When a wound separates, the body doesn't just leave it open. It floods the area with fibrin to create a temporary fibrous mesh.
So it's supposed to be there.
It is a completely normal, healthy byproduct of secondary healing. It looks alarming to the untrained eye, but it is literally just the body's mortar trying to patch the broken bricks.
And the prescribed treatment for a fibrin-covered separation is wild. You don't rush them back into surgery. You don't blast them with heavy systemic antibiotics. The primary clinical advice is often just to keep the area meticulously dry.
Yep.
They literally advise patients to use a standard hair dryer on a cool setting after a shower. You just blow cool air onto the wound to ensure it stays completely dry so the fibrin can calcify and do its job.
It really demonstrates how incredibly resilient the surface skin can be if you simply manage the moisture, the tension. But, as challenging as the external scars and dehiscence are, they pale in comparison to what happens inside.
Yeah.
The most rigorous, demanding, and fiercely contested healing process happens entirely internally.
This is the internal battle. Because as much as the surgeon has carefully engineered and constructed this brand new vaginal canal, the patient's immune system does not recognize the blueprint.
Not at all.
The body looks at this new cavity and essentially sets off a massive biological alarm. It perceives the canal as a massive gaping wound that needs to be closed immediately.
It is a profound, aggressive biological response. The body naturally attempts to heal any internal open space by contracting the surrounding tissue and rushing to fuse the walls together.
Just trying to seal it shut.
Exactly. And if this physiological response is left unchecked, it results in vaginal stenosis. Stenosis is the rapid narrowing, shortening, or in severe cases, the total fusion and closure of the newly created canal.
So to stop the body from erasing the surgery, patients have to commit to a lifelong reality of vaginal dilation. And reading the postoperative protocols for this in our stack of sources, it is staggering.
It's a massive commitment.
I kept thinking of an analogy. It's kind of like getting your ears pierced, but on a massive structural scale. If you don't keep an earring constantly in that piercing for the first year, your body's defense mechanisms will stubbornly and aggressively close the hole.
Except in this scenario, the earring is a rigid medical-grade dilator, and the physical stakes are infinitely higher. It is not just a casual post-op task. It requires a fundamental reorganization of the patient's daily life.
The timeline for this is grueling. It starts about 7 days after surgery, basically the moment the initial surgical packing is removed. Patients must insert a dilator into the canal for 15 solid minutes per session.
Right.
And they have to carefully angle it, curving up toward the navel to follow the precise anatomical path the surgeon carved out. For the first month, they have to do this 4 times a day.
That is a dedicated, painful process every 6 hours, around the clock.
And then it tapers to twice a day for months 2 through 6, once a day for months 7 to 12, and then dynamically, meaning weekly to monthly for the rest of their lives.
It never really ends.
Right. Patients use a structured kit of 4 to 5 numbered dilators, starting with a narrow one and slowly graduating. The clinics require them to eventually reach and maintain at least the green dilator, which is size 3, to ensure functional depth and width.
The physical mechanics of holding a rigid dilator inside a healing surgical site for 15 minutes, 4 times a day, introduces a severe psychological and neuromuscular toll.
I can't even imagine.
Pain, or even just the anticipation of pain, triggers a secondary defense mechanism in the body, which is muscle guarding. The trauma of the surgery itself can cause pelvic floor hypertonicity.
Expanding on our ear-piercing analogy, imagine if your earlobe actively spasmed and violently clenched shut every time you tried to put the earring in. That is what pelvic floor hypertonicity is. The pelvic muscles involuntarily clench up and lock down.
It is an uncontrollable protective reflex. When the pelvic floor goes into spasm, inserting the dilator becomes excruciatingly painful and sometimes physically impossible.
Which creates a terrible loop.
Exactly. It creates a brutal cycle. The pain causes the spasm makes dilation impossible, and the lack of dilation allows stenosis to set in. This is exactly why specialized pelvic floor physical therapy is now considered a mandatory pillar of recovery.
They need help learning how to relax it.
A trained physical therapist has to teach the patient how to map their own anatomy, recognize the spasm, and consciously relax those specific internal muscles so they can dilate without fighting their own body.
So we have to ask the ultimate question. What happens when the worst-case scenario occurs? Let's say the hypertonicity is too severe, or a patient gets sick and misses their strict dilation schedule for a few weeks, and severe vaginal stenosis sets in.
Right.
The body wins. The canal shrinks to a fraction of its size or closes completely. Is it game over? Or can an entirely closed internal space be salvaged?
Historically, severe stenosis was considered catastrophic. The scar tissue is so dense that simply pushing a dilator harder won't work. It will just tear the tissue.
Oh, wow.
But surgical innovation in this specific area is moving at lightning speed. Surgeons are developing next-level salvage operations to re-engineer that lost internal space.
Our sources outline a few of these salvage methods, and they legitimately sound like science fiction. The emerging best practice right now involves a robotic surgical approach.
Yes, the robotic peritoneal flap.
Right. Surgeons use highly precise robotic arms to go in and pull down a peritoneal flap, which is tissue taken from the smooth internal lining of the abdominal cavity, to completely rebuild the walls of the canal.
The peritoneal flap is highly promising because the tissue is incredibly resilient, and the robotic approach is remarkably minimally invasive compared to older open abdomen methods. However,
Which is always a however.
always, the medical literature adds a crucial caveat to this technique. We currently lack long-term data on whether this specific flap removes the need for lifelong dilation. Because the procedure is relatively new, we just don't have the decades of clinical follow-up required to know if the abdominal lining eventually tries to contract the same way skin does.
While we wait on that data, there is another salvage technique detailed in the sources that absolutely blew my mind. It's called a buccal mucosa graft. There is a specific, detailed case study in our stack about a 34-year-old transgender woman who lost her neovagina to severe complications.
Right, I read that one.
She was left with a canal that was only 2 centimeters deep. She dutifully dilated every single day for an entire year with absolutely zero success. The body had walled it off.
The internal space was essentially gone, so the surgical team had to look for replacement tissue that didn't rely on the compromised pelvic blood supply. They looked inside her mouth.
They harvested 2 large grafts of tissue, each about 3 by 6.5 centimeters from the inside of her cheek and her lower lip. But they couldn't just paste cheek tissue into a pelvic cavity, right? They had to heavily modify it. First, they defatted the tissue, meticulously scraping away any subcutaneous fat to get down to the pure mucosal layer. Then they made 25 to 30 sharp fenestrations.
Fenestrations are tiny, precise surgical holes spaced about 1 to 2 millimeters apart, covering the entire surface of the graft.
The mechanism behind this is brilliant. Think of a baker cutting tiny slits into a loaf of bread dough before putting it in the oven. Those slits allow the dough to rapidly stretch and expand without tearing. By cutting those tiny holes into the cheek tissue, the surgeons drastically increased its surface area. They wrapped this freshly expanded cheek tissue around a silicone vaginal mold and inserted it into the pelvis to force the body to adopt it. And the result. 6 years later, the clinical follow-up showed this patient successfully maintained an 11-centimeter deep canal, sourced entirely from the inside of her mouth.
It's incredible. The success of the buccal graft really highlights the staggering adaptability of human mucosa. The mucosal tissue inside your mouth is biologically almost identical to vaginal mucosal tissue.
That's wild.
It is hairless, it naturally thrives in a constantly moist, high-friction environment, and it is highly vascular. When introduced to the pelvic region, the body recognizes those similarities and integrates the graft seamlessly.
Yeah.
It is an incredibly elegant biological workaround.
And the field is pushing even further past human tissue. The sources touch on the absolute experimental frontier of salvage operations. Surgeons are actively experimenting with using Nile tilapia fish skin as a biological dressing inside the canal to prevent stenosis.
Yep, fish skin.
They are also utilizing 3D printed bioscaffolding to maintain the space.
The leap to fish skin sounds absurd until you look at the cellular biology. Tilapia skin is exceptionally rich in type I and type 3 collagen, which is basically the holy grail for human tissue regeneration.
Oh, wow.
Yeah, when sterilized and placed inside the canal, it doesn't just act as a physical barrier, it provides a highly organized collagen matrix. The patient's own human cells migrate across this fish skin scaffolding, using it as a biological ladder to rebuild healthy tissue, instead of laying down rigid scar tissue. It accelerates healing while actively preventing the canal from shrinking.
So to bring all of this together for you, we started this deep dive looking at a highly engineered, deeply restrictive architectural project. We saw that the human body can be profoundly stubborn.
Very stubborn.
It fights the blueprint. Driven by the strict limits of blood supply, it heals asymmetrically, it pulls violently at the suture lines, and it aggressively tries to close up the internal spaces we try to open. We asked if these intense complications could actually be corrected.
And the medical literature proves that they absolutely can. Science is matching the body's stubbornness with breathtaking creativity. We've seen how allowing the blood supply to safely stabilize makes secondarily labiaplasties incredibly effective for fixing asymmetry.
Right.
We've seen how rearranging the tension of a scar with a Z-plasty changes how the skin behaves. And we've seen how transferring mucosal tissue from the cheek can entirely resurrect a lost surgical space.
It really leaves you with something to chew on. As we move from borrowing skin from the living room to pull off a renovation, to pulling down abdominal lining with robotic arms, to utilizing fish skin collagen and 3D printed scaffolding, we are officially entering an era where surgical reconstruction is becoming less about just moving parts around and much more about advanced biomaterials and cellular engineering.
It fundamentally changes the paradigm of what a reconstructive surgeon is. They're no longer just anatomical mechanics, they are bioarchitects, tricking the body into building the structures they want.
Exactly. It makes you wonder, as this specific technology accelerates, how will the boundaries of human tissue adaptation continue to expand in the next decade? If we are seamlessly integrating cheek tissue and fish skin today, what will the surgical blueprint look like tomorrow?
It's a fascinating frontier.
It really is. Thank you for diving deep into the material with us today. It's been an incredible journey through the complex resilience of the human body, and we're so glad you came along for the ride. Catch you on the next deep dive.